We are live now, doctor.
Thank you. A very good afternoon to one and all. I'm Dr. Ritu Singh, here to host you, one of the three moderators for yet another Prelims Session number 8 of YOSI iROCK. We are thrilled to have four eminent judges who will be judging four amazing participants pan-India here. Let's go through a rocking introduction of all these participants and judges. That was a boombox introduction to you all. We have here the governing council members of the tenure 2024-26 of Young Ophthalmology Society of India, backed by the young and dynamic executive members. Now, YOSI is an amazing platform for the ventures and development of residents and young ophthalmologists, and one of the arms of it is YOSI iROCK, the logo of which was designed by our secretary, who is with us today, Dr. Nilesh Kumar sir. This is the core team of YOSI iROCK, which was the brainchild of Dr. Nupur Goel ma'am. She leads the team, and the team has persistently conducted fantastic marathons of prelims themed oculoplasty, glaucoma, cataract, neuro-ophthalmology, cornea, uvea, and we are here with another glaucoma prelims session. I'll brief you with the instructions of YOSI iROCK. We here have each team with 3 members. Today we have 4 teams, each having 3 members. The junior residents are here from various institutes, and the top 2 teams today will go for further rounds. The results of this prelims will be announced tonight by 8 p.m. as a flyer, and all the participants will be awarded e-certificates. The wonderful finalist teams will be labeled YOSI iROCK stars. They'll be competing amongst each other in the YOSICon, which is hosted in New Delhi, India Habitat Center this September from 5th to 7th. So see you all there. And also the top 3 teams in the grand finale will be awarded travel grants and will be titled YOSI iROCK Superstars. We have 4 rounds today: iLeague, Pupils Got Talent, Knowledge Nexus, and Wordsmith War. And not just that, the audience are to be vigilant and take participation as well, because they have exciting prizes to win. With pleasure, I'm here to introduce 4 of our judges today. We have Dr. Sushmita Kaushik ma'am, who is the professor in Advanced Eye Center, PGIMER, Chandigarh. She has 175 publications in indexed international and national journals with 51 chapters in various textbooks, and has also authored one of the modules in World Glaucoma Association. She's the founder secretary of Indian Pediatric Glaucoma Society, former secretary GSI, and senior vice president in Chandigarh Ophthalmological Society. Ma'am has been an invited member from India for the Childhood Glaucoma Research Network, a visiting professor at Bascom Palmer Eye Institute, member of CDSC of Ministry of Health and Family Welfare, and also member task force of Indo-US Joint Proposals. She has many accolades to her name, some of which to name are B.K. Narayan Award, Noel Rice Lecture, Rustam Ranji Award, and honorary awards and keynote lectures at Royal Manchester Eye Hospital and L.V. Prasad Eye Institute, Hyderabad. Ma'am is also a recipient of Ophthalmic Hero Award from AIOS in 2017, 23, and 25. Thank you so much for joining us, ma'am. Next, we have Dr. Sirisha Senthil, ma'am, faculty and head VST Glaucoma Center, L.V. Prasad Eye Institute, Hyderabad. Ma'am is a highly accomplished ophthalmologist with over 24 years of experience in the field. She's currently heading the glaucoma service, and her areas of interest lie in refractory adult and pediatric glaucoma and drainage implants, secondary glaucoma, and genetics of inherited childhood glaucoma. She has several presentations such as, and on various platforms, and has received Best Scientific Paper Awards and Best Video Awards at the GSI, AIOS, World Ophthalmology Congress, etc. She has published over 200 scientific papers, authored several book chapters, and she also has a few titled named awards such as Dr. Vengal Rao Medal, IJO Silver Award, and American Academy of Ophthalmology Achievement Award in her basket. Thank you so much for joining, ma'am. Next, we have Dr. Rita Dhamankar, ma'am. She's the head of glaucoma services, Lakshmi Eye Institute, Mumbai, and principal of Lakshmi College of Optometry. She had done her graduation and post-graduation from Grant Medical College with a feather in her cap with the Dr. Dastoor's gold medal. Ma'am has been trained with stalwarts in glaucoma subspecialties such as Dr. G. Chandrasekhar sir and Dr. Ravi Thomas sir before she proceeded to head the Department of Glaucoma. She has given guest lectures nationally and internationally and also won prizes for her presentations at MOS, BOA, and AIOS. Ma'am has written numerous chapters in textbooks and many papers in peer-reviewed journals. Not just this, she is also a pioneer in working with selective laser trabeculoplasty in India. Academics apart, she works in a Lakshmi Charitable Trust, which is committed to serve the poor and needy in terms of eye care. She has been a participant of many national and international clinical trials too. Thank you so much for joining, Rita, ma'am. We have last but not the least Dr. Julie Pegu, ma'am. She's a senior consultant in glaucoma and cataract services at Shroff Charitable Eye Hospital, New Delhi. Ma'am is a clinical adjunct professor in University of Wisconsin and in charge of cataract training program and also mentor in the medical officer program. She's passionate towards teaching and helping eradicate the blindness from glaucoma. She has special interests in pediatric, secondary, and complex glaucomas, has over 50 publications to her name, and has received more than 10 hours in the awards at various platforms. And not just that, she holds interest in co-curricular activities such as playing table tennis and badminton too. Thank you so much for joining in. I'll now request Dr. Arshi ma'am to go ahead with the introduction of moderators. Over to you.
Thank you, Ritu, and thank you so much to all our esteemed judges for being here. I would invite our participants to make use of this opportunity to interact with these stalwarts, and they are wonderful people as well, and you've already heard their name and their accomplishments. So have a good time interacting and learning from them. Our moderators for today are, first of all, our YOSI iROCK team lead, Dr. Nupur Goyal. She completed her long-term fellowship in comprehensive and oculoplasty from LV Prasad Eye Institute, Hyderabad, and is currently working as a consultant in anterior segment and oculoplasty at Eye Care Eye Hospital and PG Institute, Noida. She has a keen interest in academic, is also a managing editor for the Yo Times, and is a YOSI sociocultural team leader and has many accolades to her name. Thank you so much, ma'am, for coordinating everything. She's been the person behind the scenes. She's been the rock and the heart and soul of this program. We thank her for all her efforts. Then there's me. I'm Dr. Arshi Singh. I'm an assistant professor at Guru Nanak Eye Center in glaucoma services at Maulana Azad Medical College, New Delhi. I did my MBBS from AIMS and thereafter my DNB ophthalmology from LV Prasad Eye Institute. I'm also a UC executive member. Then I would like to introduce my co-moderators for today. Dr. Sameer Chaudhary. He's done his MS in ophthalmology from Arvind Eye Institute, Madurai. He's a consultant at this present moment at Arvind Eye Hospital, Madurai, and is an executive member of the YOSI. He's had done his FICO and has multiple publications, more than 25 publications at this young age with 3 book chapters. Is also a reviewer for international journals. He's a very keen FACO and SICS trainer and has performed more than 400 cataract surgeries. Welcome, Dr. Sameer. The residents would have a good time interacting and learning from you. He's also a person who's actually interested in the residence training program. And then we have our very enthusiastic and very talented Dr. Ritu Singh. She's an assistant professor at AIMS Capfins, New Delhi. She did her ophthalmology from King's George Medical University in Lucknow. She has more than 30 presentations and 6 index publications. She's the recipient of the AIOS IGO Silver Award, the MC Luthra Award at UKSOS, and the Best Paper winner at DOS. She's also a YOSI executive member. Welcome, Dr. Ritu. Now, we'd like to introduce you all to our participants for the day. Today's preliminary session has our first team from AIMS Raipur, Team Luster, headed by their captain, Dr. Aisha, who's a second year resident, and Dr. Priyanshi Pandey with her as a team member, again a second year resident, and Dr. Arushi Pandey. The second team for today is Netra Ninjas from Shankar Netralaya, Chennai. First of all, I must commend all the teams for such interesting names. You come out with something different every time, and it's fun for all of us. So they are led by their captain, Dr. Amrita Subramaniam, and their team members are two second-year residents, Dr. Hussain and Dr. Swarnima Jain. Welcome, Netra Ninjas. The third team for today is from Dr. Virendra Laser Focus Surgery Center, Eye Hospital in Jaipur. Team Optic Oracles. As I said, look at these names. The captain is Dr. Gagandeep Kaur. She's a second year resident. And we have Dr. Akshita Ghia, who's a third year resident, and Dr. Amisha Mathur, a first year DNB resident. Dr. Amisha, we must congratulate you. It's wonderful to have you. It's so interested from the first year itself on the go. The fourth team for today is Team Sparkleisk from KIMS Mangalore. So their team captain is Dr. Navyashri, who's a second year postgraduate resident. The other team members are Dr. Habiba and Dr. Simran, who are second year and first year postgraduate residents, respectively. Welcome to all the teams. All the best for everything and have a really good time today. Over to you, Dr. Samir.
Uh, thank you, Dr. Arshi. Before we start our formal session, I would like to invite our dynamic secretary, Dr. Nilesh Kumar sir, to address the audience today. Over to you, sir.
Thank you, Samir, for having me, and congratulations to everyone who is involved, starting from Nupur ma'am to Dr. Arshi to Dr. Ritu to you, Dr. Samir, for getting together all the teams. And I have seen the behind the scenes and how busy it has been getting the prelims, the demo round and everything done. So very well conducted and very meticulously done. I would also like to thank our judges for taking out time and being here. We have seen them throughout our career, starting from our residency, and now having them as judges is an honor. So welcome, ma'ams. And we would extend our, like on behalf of Governing Council and YOSI, I would extend my invitation for you all to be with us physically at YOSICon in September, where you will see all these. There will be two stages of these physical quizzing over there, and we are going to award them big time. Like they will mostly get travel grants and whatnot. So it will be our privilege to have host you all there. Thank you, everyone, and all the best teams. Looking forward for this afternoon.
Thank you so much, sir. So with this,
Just a second, I forgot to mention that all our teams also have mentors today. They're consultants who are here, and I would like to welcome them too. Can I just say their names so that they can all also be acknowledged? The Team Luster has Dr. Pratima Sahu as their mentor today. Team Netra Ninja has Dr. Shushrut here today, who is the neuro ophthalmology consultant. Team Optic Oracles has Dr. Neha Pathak. Welcome, ma'am, and thank you for being here today. And Team Sparkleisk has Dr. Ashley Biju, who's their consultant and mentor for today. Thank you to all the mentors for being supportive to your teams and for being here today for them. Over to you, Samir, again.
So just to provide an overview of the session today. So we'll have 4 rounds. The first round would be a seminar presentation, specific, or like we'll be discussing about each round as it comes. This is followed by a creative round where the various teams will be presenting reels about social awareness. Then there will be a quiz round followed by a unscramble round. So to begin with, we'll have the iLeague, which is a seminar presentation. So each team has been given a specific topic related to glaucoma, and the judges like should make a note of this. So they'll be judging each presentation on the basis of content, clarity, presentation, followed by the ability of the particular person or the team to answer the questions that they are asking. So each team is given 5 minutes to present, and there is negative marking for exceeding the time limit. Then for question and answers, there will be 2 minutes, which will be following up the presentation. So there are total 20 marks, and each one person will be presenting from each team. So the theme for the today's this thing is glaucoma. So with this, I would like to invite the first team, which is Team Luster, and they'll be presenting on primary angle closure glaucoma. Over to you, Team Luster.
Yes, sir. Good afternoon, everyone.
Please share your screen.
Can I start?
Yes, please start.
Good afternoon, everyone. Today's topic is primary ankle closure glaucoma. Ankle closure refers to the occlusion of trabecular mesh by the peripheral iris obstructing aqueous outflow. Can be primary when it occurs in an anatomically predisposed eye. ISGEO classified primary ankle closure disease into three types. Primary ankle closure suspect with at least 180-degree iridotrabecular contact on gonioscopy. Primary ankle closure with at least 180-degree iridotrabecular contact on gonioscopy, raised IOP and peripheral anterior synecdoche. Primary ankle closure glaucoma is primary ankle closure with evidence of optic and visual field changes. The main mechanism is relative pupillary block. In anatomically predisposed eyes, there is lens iris apposition at pupil, which leads to aqueous accumulation in the posterior chamber, leading to formation of iris bomb and result in narrowing and closure of the ankle and increased IOP. The anatomically predisposed eyes are those eyes with shallow AC, short axial length, small anterior chamber width, large iris volume, increased lens wall thickness. This results in angle closure. Another mechanism is plateau iris. Plateau iris configuration is more anteriorly positioned ciliary process, pushing the peripheral iris forward, and which is seen as double hum sign on gonioscopy. The plateau iris syndrome is development of angle closure spontaneously or after pharmacological dilation in an eye with patent PI. Primary angle closure glaucoma can present as acute angle closure glaucoma with symptoms such as sudden severe pain, nausea, vomiting, redness, photophobia, and blurring of vision, with signs such as lid edema, conjunctival chemosis, corneal edema with microcyst, shallow AC with cells and flare, semi-dilated vertically oval fixed pupil with IOP ranging between 40 to 70 mmHg, gonioscopy with closed angle, and optic disc can be edematous or hyperemic. Subacute angle closure can have repeated brief episodes with mild symptoms and ocular symptom-free intervals. While chronic angle closure glaucoma is generally symptomless with high or normal IOP, shallow AC with pupillary rough atrophy, patchy iris atrophy, posterior synecdoche, glaucoma flecken, and in gonioscopy, peripheral anterior synecdoche with visual field and optic disc changes. Coming on to management, acute angle closure is an ocular emergency. So patient is advised to lay in supine position. IV mannitol 20% is given at 5 ml per kg. Tab acetazolamide is given. Topical glaucoma medication is added. And once the corneal edema is decreased, then topical pilocarpine 2% is instilled, followed by laser peripheral iridotomy in both eyes. Coming on to the management of chronic primary angle closure glaucoma, the main goal is long-term IOP management, preventing the progression of optic neuropathy and manage synechial closure. The mainstay of treatment is laser peripheral iridotomy. And if IOP remains elevated or the angle closure persists even after laser peripheral iridotomy, then topical medication like prostaglandin analogs, beta blockers, and carbonic anhydrase inhibitors can be added. Coming on to the surgical management, a randomized control trial was done for the effectiveness of early lens extraction for the treatment of primary angle closure glaucoma, and it showed that clear lens extraction results in a decreased IOP, increased cost effectiveness, and increased quality of life when compared to peripheral iridotomy. Another technique is phacogoniosynecholysis, which is an optimal procedure which is superior to phaco alone or phacotrabeculectomy. And if the IOP remain uncontrolled on maximal medical therapy or if there are repeated attacks of acute angle closure, then filtering surgery, trabeculectomy can be done. But the next question is, should PI be done in all primary angle closure suspect? It is a trial was done, Zongshan ankle closure prevention trial. We showed that Widespread prophylactic laser peripheral iridotomy is not recommended on a population basis. It is recommended in eyes with fellow eye with PAC or PACG. If there is a family history, if there is anatomical predisposition, or if there is frequent pupillary dilation required. Thank you.
That was a great presentation, very well covered. With this, I would like to invite Dr. Sushmita ma'am for her comments and questions.
Right, great presentation, as you said, and congratulations for putting this together in a short time. Just one comment that when you're giving definitions, you have to stick to them. So the ISGO definition actually talks in terms of occludable angle and then defines PACS, PAC, and PACG with or without previous signs of angle closure attack, which is PACS and PAC, or raised IOP, and of course with disc and field changes. So just stick to definitions. And when you're talking of a classification, then remember that chronic angle closure and all that don't come into the ISGO classification. So I think both were lumped together. It's nice to say that in a clinical context, it is also classified as chronic and acute and all that, because that's not part of the ISGO. But other than that, it was fine. Thank you.
Thank you for your valuable comments, ma'am. Dr. Rita ma'am, would you like to?
Yeah, I was wondering that she's given us treatment for angle closure. Do you really believe in early clear lens extraction as a treatment for angle closure glaucoma? You mentioned the study, that's why I'm asking you its clinical implications.
Yes, ma'am. In anatomically predisposed eyes like increased lens wall thickness, if early lens extraction is done, then it can IOL implantation is done, then we can prevent from other attacks.
Do you think it is safe to do an early clear lens extraction in a patient with angle closure glaucoma vis-a-vis doing just a peripheral iridotomy?
It is done if primary angle closure with IOP more than 30 mm, 30 millimeters.
The IOP, it's not the question of IOP. I'm just saying, is it safer to do the surgery for a clear lens extraction vis-a-vis doing a peripheral iridotomy? Because when you're doing a lens extraction, remember the patient is losing his accommodation completely.
Yes.
And you're opening the whole eye, so more susceptible to infection. So have you taken that into consideration?
Yes, ma'am.
Yeah. You should
Yes.
go through that EAGLE study properly, because there are a lot of ifs and buts about the EAGLE study. Yeah?
Yes, ma'am.
Thank you. Nice presentation.
Thank you, ma'am. Dr. Sirisha ma'am.
Hi, Aisha and Team Lustre. A good presentation. So I think I agree with the comments that were given earlier. And if you look at the definitions, maybe you may want to go back and relook at how a plateau iris syndrome is defined. Plateau iris configuration is something that you put up, but plateau iris syndrome, I don't think the definition was appropriate. And also, I think most important as postgraduates and as somebody who's just starting to learn angle closure glaucoma, I would say one should give importance to the evaluation. Meaning like gonioscopy is something that is very, very important, and it would be nice if even that was added, types of gonioscopy and what each of them actually mean and how that is useful in the management, because ultimately that's what guides you, right?
Yes, ma'am.
Yeah. So that's all I had.
Thank you, ma'am. Dr. Julie ma'am.
Yeah, hi Aisha and Team Lustre. Nice presentation, and it's a good overview. But like all the judges have mentioned, I think those points mean a lot. Okay, so because we have a lot of students here, so when you are examining a patient and you have done a gonioscopy and you see that the angles are occludable, okay, so do you think that dilatation can have a change in the angle configuration? I think that's my question. I mean, how dilatation of an eye can have an effect on the angle configuration? I mean, is there a change?
Yes, ma'am. Dilatation can lead to increased crowding of the angle. The iris can come more close to the trabecular mesh, but
Does it always happen like that, or
increased crowding of the angle structure.
does it always go further into closure, or do you think that some of the angles can open up depending on the position of the ciliary processes and the ciliary body? So for that, I think you have to do algonioscopy in all dilated eyes as well and find out, what kind of angle configuration change can happen with dilatation. Depending on the position of the ciliary processes, some of the angles further go into closure and some of the angles actually open up because of the backward movement of the lens and the iris diaphragm. I think overall good. Thanks.
Thank you. Thank you, ma'am. I think your the mentor for Team Luster is here, Dr. Pratima, ma'am. Ma'am, would you like to say a few words? Dr. Pratima, ma'am.
Ma'am, please unmute yourself.
I think we'll get back to her. We'll move on with the next presentation in the meantime. So I would like to invite the next team, Team Netra Ninjas, who will be presenting on lens-induced glaucoma. Over to you, Team Netra Ninjas.
Can I start?
Yes, please.
Okay. Good afternoon. Our topic for today is lens-induced glaucoma. And this is Dr. Amita, Hussain, and Swarnima from Shankarniti. So like any glaucoma, it can be classified as open or closed. Moving on to the open type, phacolytic glaucoma is when high molecular weight lens protein leaks to an intact capsule and robs the trabecular issue. So it's in the background setting of a hypermature or a Morgagnian cataract. As the lens ages, the capsule stretches, and this causes leaking through the microscopic openings in the lens capsule. These are eventually phagocytosed where the macrophages unblock the tear, or they directly block the trabecular issue. So these patients usually have a long-standing decrease in vision, but present to us with acute drop in vision or pain or redness, and associated increased IOP symptoms such as headache and vomiting. They also have signs of increased IOP such as conjunctival hyperemia, corneal edema, AC clearances, but characteristic lens protein and macrophages in the anterior chamber, along with the Morgagnian cataract, and sometimes white deposits in the anterior lens capsule. But these protein capsules are microscopic. If it's macroscopic, it is usually lens particle block. This is when lens particles block the trabecular issue, ruptured capsule with a recent trauma or surgery. These patients have acute symptoms and they have free floating cortex in the anterior chamber. And usually sometimes the cortex can be so large mistaken for a pseudohypoplasia. Phacoantigenic glaucoma, also called as phacoanaphylactic, is a type 3 hypersensitivity reaction to patient's own lens protein post a surgery or a trauma. It has a latent period of 1 to 14 days and presents as a granulomatous inflammation. So here we can see medium to large sized KPs on the endothelium. And because of this inflammation, there can be a synanche and a low-grade vitritis. Coming to the closed type of glaucomas, this is a phacomorphic glaucoma where an increased anteroposterior length of the lens leads to an iridolenticular contact, leading to a pupillary block, iridotrabecular contact, and subsequent angle closure glaucoma. This closure can be appositional or synanche. So who are the patients who have increased anteroposterior length of the lens? Are those with intermittent cataract, hyperopic eyes, traumatic cataract, pseudoexfoliation, and pre-existing narrow angles. So these patients with long-standing phacomorphic have precipitated symptoms at night due to the dilation. And the signs include shallow AC, closed angles, mid-dilated pupil, intermittent cataract, and it's important to check the fellow eye and perform a gonioscopy to rule out occludable angles. A short note on ectopia lentis. Ectopia lentis is a congenital dislocation of lens. Its lens is displaced completely from the patella fossa into the AC or the vitreous. It can be with systemic association or without. And how this causes glaucoma is pupillary block by lens or vitreous, narrowing of an angle recession, or a coincidental angle anomaly or chronic open angle glaucoma. Coming to the management, the conservative management is to lower the IOP with medical management, and definitive management is to surgically extract the lens. So coming to the conservative management, we can use aqueous suppressants such as alpha agonists, beta blockers, carbonate anhydrase inhibitors, and suppress the inflammation with topical steroids and cycloplegics. And it's important to give preoperative hyperosmolarity agents such as 20% mannitol or 50% oral. And is there a role of laser iridotomy? Yes, in cases of phacomorphic eye, especially in the fellow eye, if there is occludable lens. And removing the lens is, of course, the definitive treatment. Preoperatively, it's crucial to perform a B scan to know the posterior segment status and the disc status if it's not visible during examination, and to control the IOP. And the choice of surgery varies between different cases. With ECC can be done when the view is hazy, but if IOP is not under control, there's a risk of expulsive hemorrhage, small incision cataract surgery, and phacoemulsification, avoided when AC is shallow to insert instruments or completely hazy due to corneal edema. Plus or minus IOL placement or the need of capsular tension ring or vitrectomy, and combined surgery when there is a disc cupping or a long-standing synovial angle fusion in the form of trabeculectomy plus an antenatal.
Thank you, Dr. Amrita. This was a great presentation. Dr. Sirisha, ma'am, your comments and questions, please.
Yeah, Amrita and from Netra Ninjas, very well presented. I think you covered most of the things. So just to maybe get things clear, can you just tell me what phacomorphic glaucoma is? When do you use the term
Phacomorphic glaucoma is when the lens itself causes the angle closure in cases of intumescent cataract or a short hyperopic eyes and blocks the angle.
Yeah, so I think that needs to be clarified because there's a difference between intumescent lens and a phacomorphic lens. Typically, a phacomorphic is the term that is used for a hypermature cataract, which is very large, and that is causing an angle closure. Okay, that is causing a direct closure of the angle because of the whole lens being large and it is occupying the front of the eye. So we may argue that any large lens, an intumescent lens, can also be called phacomorphic. But if an intumescent lens can also be an immature cataract, intumescent lens can have fluid clefts. It could be a lens which is pushed forward, because the examples that you gave, traumatic cataract and all of those, there also could be an anterior displacement of the lens, and that is not called phacomorphic. Okay, so that should be differentiated very clearly.
Yes.
That's the question that I had. The rest of it was very good.
Thank you, ma'am. Dr. Julie?
Yeah, hi. Nice presentation. Overall, you described the findings very well. And I think Shirisa ma'am has explained the definitions also. So my question would be like, if you have a phacomorphic patient with high intraocular pressure, would you do a PI? And then proceed ahead with the surgery, or you would not prefer to do a PI and go ahead with the surgery?
Ma'am, if there is time, we would do the PI and then proceed with the surgery. But if there is no time, we would proceed with the surgery first, because the eye is already inflamed, and if you do a PI, it just leads to more inflammation.
I mean, the difference between the phacomorphic iris and the iris of an angle closure is that in angle closure, the iris are quite thick. The volume is high. But in phacomorphic, what I've noticed is that, the iris are quite thin. They're not as thick as in primary angle closure glaucoma. So, doing a PI would always help in reducing the pupillary block element and going ahead with the surgery. I mean, there is controversy when it's about doing a PI or not doing a PI, but doing a PI would always help you. And the second question is, I suppose we have done a PI and you directly hit the capsule, and so what would happen? What do you think would happen? So one shot
First,
and it caused a PI and it also caused a lens rupture. So what do you think would happen? Would it cause a lot of inflammation, or how's it going to be?
yes, ma'am, I think it will cause a lot of inflammation because lens protein itself is toxic.
Yeah, it
And
doesn't
it
cause too
might
much of
be
inflammation, like say it's not a very liquid Morganglian type of cataract, right? So one hit in the capsule can also will maybe there will be some release of the lens matter, but not very much. And so still doing a PI maybe with a few shots in the most available location where the iris is, like where you can find a crypt would help. I mean, that's my opinion. Thanks.
Thank you, ma'am. Dr. Rita, ma'am.
Yeah.
Your
Yeah, nice presentation. It was a long questionnaire, but I mean, you presented the topic really well in that concise time. So it was nice that you could use your time quite fruitfully. But my question to you is a very simple question. You suggested surgery in terms of lens removal and trabeculectomy in all your patients. Would you really do a trabeculectomy and a lens removal in all patients who have come to you with a phacomorphic or a lens-induced glaucoma? Or are there conditions where you might not think of the trabeculectomy at all? That is my question number one. And the second question is, you said you would want to look and find out if there was a glaucomatous fundus. How many times do you think in such lenses will you be actually able to have a look at the fundus in the presence of a lens-induced glaucoma?
ma'am, for the first question, we wouldn't go with the combined surgery for all patients. The first surgery of choice will be to extract the lens. But in case we were able to visualize the disc and it had a significant cupping, or the patient has a known history of glaucoma, we can go ahead with the combined surgery. And coming to the second question, no. In cases of Morganglian cataract or intimism, it's not always possible to see the disc or examine the disc. In case we could do like an imaging before the surgery, and in case we can see the disc through that, we could possibly plan for a combined surgery based on the disc.
Supposing you're in a very small center, you're not in the tertiary eye care center. Is there still a way to find out what's the visual potential of the patient?
Maybe by doing a PAM or
think of it. Simple test.
RAPD. Yeah, PAM or RAPD, or maybe even post-op if their IOP is not controlled. Maybe post-operatively
All
we
of
can
this
do
out pre-op, na?
Yes, ma'am.
Because you have to talk to them about the prognosis, visual prognosis before you operate.
Okay. Yes.
So a very simple test.
Um,
Do you look at projection of light also?
yes, ma'am.
Yeah. So at least that will tell you whether the retina is all right in all four quadrants. Supposing
Yes,
you have
ma'am.
chromatic
We can see the
cataract,
projection.
that chromatic cataract is the cause of your lens-induced glaucoma. Don't you think that you have to also make sure that the retina is in place?
Yes, ma'am. We can do a screening test with the projection of light. Yes.
In a tertiary center where a B scan will be available to you right away.
Mm.
Okay, but you can still just do a simple test like the projection of light.
Yes.
It might not always be right, but you have done your best. Correct?
Yes.
Good.
Thank you, ma'am. Dr. Sushmita, ma'am.
Right, thank you. I think most of it has been said, and thanks for a concise presentation. But it's important to understand that phacomorphic glaucoma may not always be pupillary block. It might be a directly swollen lens pressing upon the trabecular meshwork itself. And those are the instances, like Dr. Julie said, you might have the risk of rupturing the capsule. So let me ask you a very textbook question. How would you differentiate a phacolytic from a phaco-antigenic glaucoma? These are standard round questions.
Then phacolytic's main difference is that it has an intact capsule,
Okay.
while a phaco-antigenic always has a rupture via a trauma or a surgery.
All right.
And phacoantigenic has like a latent period. And you can have KPs on the endothelium.
You're going to have KPs, whereas because both will present as a very uveitic sort of glaucoma with a lot of inflammation and high pressures. But yes, you won't have KPs in a phacolytic, whereas you would. And I agree with Dr. Rita that the first thing to do is just take out the lens and take a call. You know, doing a trabeculectomy in an inflamed eye is not a good idea at all, because your trabecular bleb is not going to work very well. If there is a lot of inflammation, it's going to scar down. So give steroids pre-op, whiten the eye as much as you can, do it under mannitol, take the lens out, hold on. Nothing is going to happen. Of course, the conversation has to be that I'm going to look at your pressures later, I'm going to look at your angles. And it could be that medically I can't control you, and then we'll do that as a second step. But don't try to go in and do a trab in a hot eye, ever. Whiten your eye before you do it.
Thank you, ma'am. Nethan Ninjas is your mentor there.
Yeah, good afternoon all. I'm here. Thank you, Amrita, for the very interesting presentations, and thank you all the judges for the very enlightening and interesting discussion of this topic. Thank you so much.
Thank you, sir. I feel there was a lot of learning in that particular presentation, the discussion that followed it. With this, I'll invite the next team, which is Team Optic Oracles, to present on childhood glaucoma.
A very good afternoon to all. Today I'll be presenting on the topic childhood glaucoma. Childhood glaucoma are a rare heterogeneous group of disorders associated with elevated IOP. Clinical presentations are quite variable depending on the age of onset and the severity of IOP elevation. Parents and primary care providers have a very important role of recognizing the abnormalities early and thereby helping in early diagnosis. And if substantially delayed, there can be devastating consequences. It could either be a primary or a secondary childhood glaucoma. In primary, we have primary congenital as well as the juvenile open angle glaucoma, and there are further subcategories on depending on the age of onset. In secondary glaucoma, we have depending on their etiology. It could be either non-acquired ocular, non-acquired systemic, or acquired conditions, or following a cataract surgery. The primary congenital glaucoma is most common form of primary pediatric glaucoma, and the risk is quite increased by consanguinity. It's mostly bilateral. Male preponderance is seen, and mostly in neonates. That is 25% of the patients. Main pathology is trapecular dysgenesis, an anterior insertion of the iris root, which impedes the aqueous outflow, thereby increasing the IOP. And the Barton hypothesized that this resistance was caused by a membrane which covers the anterior chamber angle, which now is quite controversial. The history should be taken of the glaucoma or any consanguineous marriages in the family. If so, the high IOP causes epithelial edema, thereby irritation of the corneal nerves. And the triad of symptoms, that is the epiphora, photophobia, and blepharospasm is seen. Whitish appearance of the cornea and large eyeballs or the asymmetry between the two is also taken noticed by the caretaker and reported. The signs are raised IOP, which could be taken by handheld Perkins tonometer, tonopen, or rebound tonometer, and examination under anesthesia is done for neonates. Buphthalmos with corneal diameter more than 12 mm and axial length more than 20 mm in neonates is suspicious. And this is the abnormal enlargement of the infant's eye seen in congenital glaucoma, secondary to the raised IOP. The Harb's striae as shown in the pictures, that is the horizontal breaks in the decima membrane, ultimately causing corneal edema and haze. In ongonioscopy, there is a anterior iris insertion and underdeveloped trabecular meshwork, and initially reversible, but then ultimately irreversible cupping can be seen. And retinoscopy and refraction is a must for myopia and astigmatism, which could cause amblyopia. And examination under general anesthesia is generally required. Perimetry can be done in older children. beyond 5 years of age. In treatment, the main treatment is surgical, but medical can be done to lower the IOP before surgery or after surgery for adjunctive purposes, and various classes are used. Among these, alpha-adrenergic agonists are prevented below 6 years of age because of the respiratory depression, because of blood barrier, the crossing that they do. Surgically, we can go for angle procedures like goniotomy in clear cornea, or we can go for trabeculotomy, in which we inserting a fine instrument into the Schlemm's canal and breaking through the trabecular meshwork. Other surgical techniques are trabeculectomy or combined with trabeculotomy, deep sclerotomy, drainage devices, and ultimately cyclodestructive procedures. Then there is another entity called juvenile open angle glaucoma, which is a form of primary angle glaucoma which presents between first and the late 30s. Presentation is with high myopia and with associated myopia, which has a quite high incidence. And gonioscopy, contrary to the primary congenital, we see normal angles with prominent iris processes, and there is no corneal enlargement or half stripe because of the later age of onset. And the first line of treatment in this is medical management, and surgery might be required. And in secondary childhood glaucoma, the causes, as we discussed earlier, are various. In non-acquired ocular, we have mainly Axenfeld Rieger, Peters anomaly, and aniridia, microcornea. And in non-acquired systemic, we have neurofibromatosis, Sturge-Weber, and associated conditions which are acquired are uveitis, trauma, and few entities are like Axenfeld Rieger, in which we see posterior embryotoxon, and another picture shows us the full thickness iris hole with correctopia and iris adhesions to the Solvay's line. In Peters anomaly, we see central corneal leukomatous opacities with iris adhesions to it, and sometimes the lens also adhered there, which might also be a differential diagnosis for the haze. And aniridia is another cause. Take-home message is that childhood glaucoma constitutes a heterogeneous group, which is serious, and children share the clinical features depending on the age of onset and the severity of IOP. And early recognition is necessary, and a collaborative effort of ophthalmologist, family, patient, and school and community. The references are Thank you so much.
Thank you. Thank you, team of the corridor. And with this, I would like to invite Dr. Sushmita ma'am for her comments and questions.
So, what is the classification that you use to classify this childhood glaucoma? It's a huge topic. For 5 minutes, it's a tall order. So
Yes,
thank you
ma'am.
for trying to condense it.
So
what classification did you use for which you told us?
Ma'am, there's also Hogan's classification with classes.
What is the one that you talked about? The one that you presented, which is what most of us use.
Ma'am, it's Becker's paper was there. I'm forgetting.
The Childhood Glaucoma Research Network's classification, okay, CGRN. And it's important to mention what classification you're classifying any heterogeneous disorders. But of this, you've left out glaucoma following cataract surgery, which is so important that they've given it a completely different, separate heading. They haven't clubbed glaucoma following cataract surgery into secondary acquired glaucoma. So it's as important as that. And the IATS study told you that at the end of 10 years, 40% have glaucoma. So that's a very, very important cause of childhood glaucoma, right? You mustn't leave that out. And the second thing is, which the treatment that you gave was not only for primary congenital glaucoma. So when you're presenting a broad seminar on childhood glaucoma, those are principles for all childhood glaucomas, isn't it? You start medically, but the treatment is usually surgical and all that. And there was one more thing which I've forgotten. Yes, you must in today's day and age also read about minimally invasive glaucoma surgeries. You've just mentioned goniotomy, but you have many, many other surgeries for children. GAT, illuminated microcatheter, 360 degrees trabeculotomy, because those are what are being done in most pediatric glaucoma centers these days, right? So that's another thing. These are very textbookish, but these are at least, this information is about 10 years old possibly. So look, and the third thing that I would give you, one slide, 30 seconds on the fact that a lot of them are inherited and genetic testing is now possible, and it should be part of your diagnostic makeup if you can. Thank you. Sorry, you've come to the wrong person with this, the closest to our heart.
No, it was quite insightful. Thank you.
Yeah. Yes.
Thank you so much, ma'am. Dr. Julie, ma'am, your comments.
Yeah, hi, Team Optic Oracles. I mean, like ma'am said, really a huge topic for 5 minutes. Okay, so my one question would be, suppose you have put the child on treatment. Okay, now how do you know that the glaucoma is progressing? What would be the sign? Because the patient may not be ready to show you the fundus examination like an older child would do. You not put the child under you again and again, right? So what are the other parameters that will tell you probably the glaucoma is progressing if it's unilateral?
Depending on the age, if the age of the patient is more than 3 years of age, then visual acuity is quite important. And also in more than 5 years, we can go for field if fundus is not the.
No, suppose a child of probably say 1 year of age, okay, you have done the surgery, pressures are like maintained at 22 on a combination drop. Now, next what? Now, how do you know that 22 is enough or the child is progressing? So, what are the eye parameters that you're going to see just to have an idea whether that glaucoma is progressing? Just focus on the eye.
Yes, ma'am. In younger children, more less than 1 years of age, we should look for the diameter if it is progressing or not, axial length if it is progressing or not,
Yeah.
the patient is following light or not, and the torch examination thereby stands its importance. And besides that, ma'am.
Yeah, I think you got the point. I think axial length is one of the parameters that you need to have for all children that you're going to see. So that's one of the baseline parameters that you're going to note. And then if the intraocular pressure is more than what's needed, actually there will be increase in the axial length, which is more than the aged normals, matched normals. So I think that's one of the important point I wanted to highlight. Thanks.
Thank you, ma'am. Dr. Rita, ma'am, your comments.
Okay, I have very nice presentation for a very important topic, for a really large topic. Impressed that you could cover it up in 5 minutes. But in your treatment, the one thing that we must always remember is all childhood glaucomas also have refractive errors, and just treating their glaucoma never gives them adequate visual rehabilitation. So your treatment must always comprise of not just bringing the pressures down, but also of doing a good visual rehabilitation at the earliest opportunity that you get, which could be as early as a few weeks old. Because if you give them visual rehabilitation, only then are they going to see. Otherwise, amblyopia is going to set in very easily. So this is the one area where visual rehabilitation is as important a part of treatment as bringing down their pressures is. That you have not mentioned anywhere in that presentation of course.
Thank you, ma'am. Dr. Sirisha, ma'am.
I think most of it is covered and well done and a good job. Just one point maybe I would like to ask is the role of examination under anesthesia and what understanding that you have, the type of anesthetic that is used, and the way the intraocular pressure is estimated and what devices you use to estimate the intraocular pressure. I think those are very important. So are you aware of what anesthetic is used typically?
Ma'am, usually the anesthetics that we use, they lower the IOP, except ketamine, which is
What is the commonest anesthetic that today we use? Yeah, find that out. And what is the effect of that on the intraocular pressure? I think that becomes important. And then, of course, the rest of it is very beautifully discussed.
Thank you so much, ma'am. I think the mentor for Team Optic Oracles, Dr. Neha, is there. Dr. Neha, would you like to?
Yeah, very good afternoon to the judges and the participants. I want to congratulate the entire team behind UC iROCK. You're doing a wonderful job. It's a perfect mix of academics and fun, I feel. And I wish a very good luck to all the teams. Thank you.
Thank you so much. Great job, Team Optic Oracles. With this, we'll move on to the last presentation of this round. So I would like to invite Dr. Team Sparkalisk, and they'll be presenting on steroid-induced glaucoma.
Yes, sir. Grand good afternoon. I'm Dr. Navya. The pressure paradox, steroid dilemma. Let me start with a case scenario. Imagine a young boy who presents to you with allergic conjunctivitis and he quickly recovers, but comes back again with worsening of symptoms. What do you think has gone wrong? Yes, our topic is steroid-induced glaucoma. Heading back to the history, Becker and Mills reported a patient with chronic uveitis on topical steroids. The IOP rose up to 40 Hg, but it normalized on withdrawal. This marks the first recognition of steroid-induced glaucoma. So what exactly is steroid-induced glaucoma? Response to long-term steroid therapy, whether given by the topical, systemic, periocular, or intraocular route, and the IOP elevation, can lead to glaucomatous optic atrophy and loss of vision. Such a condition is known as steroid-induced glaucoma. So the exact pathophysiology is not known. However, there are many theories. So let's discuss one by one. Increased outflow resistance at the trabecular meshwork due to accumulation of extracellular matrix. So they also inhibit the phagocytic activity and leads to the accumulation of cellular debris and the obstruction. Genetic factors, there is overexpression of myocilin, which mimics primary open-angle glaucoma. There is increased expression of endothelin-1, which leads to tissue contraction and eventually the obstruction. There is also crystalline steroid particles. The intravitreal steroid injection leads to the formation of crystalline steroid particles, which physically obstruct the trabecular meshwork. So here are a few articles that are in support of the following theories. So what are the risk factors? Family history, type 1 diabetes mellitus, intraocular surgeries like LASIK, high myopia, extreme ages, connective tissue disorders like rheumatoid arthritis, and Cushing syndrome. So these are the various routes of administration, with topical carrying the highest risk and parenteral being the lowest. So what are the clinical features? There is history of steroid use, optic nerve damage, visual field defects, mainly the peripheral vision loss, and response to steroid withdrawal. All the symptoms are similar to primary open-angle glaucoma. What are the investigations? We have Goldman attenuation tonometer for IOP, gonioscopy showing open angles, ACE OCT for subtle changes, optic nerve head evaluation, and OCT RNFL for early structural loss, pachymetry for central corneal thickness, and visual field analysis. How do we manage this? If it's topical, we check the IOP at 2 weeks, systemic 4 weeks, depot 1 week. And if the IOP is more than 30 Hg with signs of glaucoma, please stop steroids and start on medical management. Then recheck the IOP at 4 weeks and then 6 monthly. But if it is less than 21 Hg, we review the patient at 2 months and then 6 monthly. So how do we prevent this? By judicious use of steroids, identify high-risk patients, patient education, regular monitoring of IOP, and use of steroid-sparing agents. So before I conclude, little drops, big surprises. Steroids help your eyes feel right, but pressure builds beyond sight. Too much can harm the optic zone. So check your eyes, don't go alone. Thank you.
Thank you for the concise and really well elucidated presentation. We'll move on to the comments by our judges. Dr. Sirisha ma'am.
Yeah, very beautifully presented, Navya. That was very captivating.
Thank you.
So of the topical steroids that are used, which do you think is the strongest steroid that's available today for us in our country?
Dexamethasone and betamethasone.
Anything more stronger than that? We'll look it up. And then which is the least potent steroid that is available to us? All right, so I think, yeah?
Loteprednol.
Loteprednol, yeah, that's right. So we should be aware, because when we say we switch from a high potent to a low potent, we need to understand which is high potent and which is which possibly has less steroid responsiveness. And we should understand how to use it as well. And what are the steroid sparing topical medications that we can use? Let's say somebody has allergy, somebody has inflammation. Now pressure is more than 30, you said we have to stop the steroids, but then if the inflammation is still ongoing, what is the steroid sparing agent that you can use?
We can use NSAIDs or any immunomodulators.
So the answer for that question would be the actual etiology, right? So is it an allergy? Is it an inflammation? It could be multiple reasons for which steroids are being used, isn't it? So that's based on the etiology. And of course, you will use, if it is anti-allergic, if it is an allergic disease, that's where the steroids are used, then you use something that is going to take care of the allergy part and the inflammation part. If it is uveitic, then it is different. So if it is, let's say, post-operative, then it is different. Okay? All right, good.
Thank you. Thank you so much, ma'am. Dr. Rita, ma'am.
Okay, nice presentation. Very crisp and short. You've done good justice to it. There are a couple of points that I sort of like to clarify. Do you think that it is only the ocular steroids that give rise to a steroid response, or do you think that we have to take a very deep systemic history? Because there are many times patients with various other systemic disorders are on prolonged steroids for their illness, and without realizing it, they come with a steroid response glaucoma. So do you think it's important or not important?
It's important, ma'am. We need to ask them. Even the systemic administration can cause raised IOP. So we
There are
have
patients, who have asthma and who are on nebulization with steroids. The patients who've got myasthenia gravis, or they've got some autoimmune disorder for which they are on a lifetime steroid, and slowly, it doesn't come up as quickly as the topical steroid response comes, but slowly over a period of time, you see that these people come with, huge glaucomatous damage because they have not been looked at for the steroid response glaucoma. So it's very important to find out when you see a glaucoma, whether there has been, misuse of steroids. Of course, the commonest is allergic conjunctivitis, for which over the over-the-counter prescriptions of whatever steroid drops are used so randomly that is probably one of the commonest causes. But there are lots of other things that you have to look at when you're looking at steroid response, right? If there is a situation where the patient needs to use steroids for his systemic condition, but his glaucoma is worsening, what will you do at such a time?
we see the risk-benefit ratio.
Would you like to talk to the physician who's kept patient on a long-term steroid? Can you discuss with him and find out whether the dose of the steroid can be reduced, whether something else can be used?
We talk to the physician, and then we also consider any steroid-sparing agents, or we start him on anti-glaucoma medications.
And you can also operate upon him, right? Okay.
Thank you. Thank you so much, ma'am. Dr. Sushmita, ma'am. Your
Yeah,
comment.
so Navya, nice crisp presentation. 5 minutes, it's not easy to cover these topics. But just one thing, you said that if the pressure is above 30, you would start on medication or something. So I think please remember that steroid-induced glaucoma can be easily reversed if you stop the steroids, especially if it's just an ocular hypertension. So if you're monitoring them well and you get pressures which are high, a prudent thing could be done is to just stop the steroids, especially if the risk is not too bad, rather than jump in and start medications and then you won't know when to stop, and you won't know whether the pressure control is because of medication or because you've just stopped the steroid. That's one. Secondly, when you define steroid responsiveness, you also have to define Armoli's definition of a rise of IOP, not absolute. It's not always 21 millimeters. Somebody who's come with 12 and comes back after that with 18, he's still a steroid responder. And that's the importance is to always check Goldman pressures before you start steroid drops and have an idea of the central corneal thickness as well. because if you've missed an ocular hypertension, and I know they're always labeled steroid responsiveness. The other small point to make out is apart from allergies, you're usually in a difficult position when a patient has come with uveitis and has raised pressures and has been on steroids. And many times it's just labeled a steroid responder. But remember, actually, you need to go back into the records and see whether or not the pressure was raised prior to starting steroids. And if so, a hypertensive uveitis requires steroids. So usually we see a lot of young patients who have been stopped steroids when they actually needed it. So just keep these couple of points in mind in practice when you do. Otherwise, nice presentation.
Great points, ma'am. Dr. Julie, ma'am.
Yeah, thank you all judges for explaining it so nicely. And I know that there may be some shortage of time. So steroid-induced glaucoma is something like iatrogenic plus ignorance, right? From the patients, the family's part also, because they keep putting medications because it gives them the symptomatic relief. So when a child comes to you with allergic conjunctivitis, so what are the specific, and you want to start on steroids, so what are the 3 things that you want to do in the child and for the child? I mean, 3 things that you're going to do.
Initially, we will not start with steroids. Maybe I'll go with antihistamines. And then, if it's still not controlling, then we'll start with steroids. And we explain the mother carefully to taper the steroids and to report if there is any blurring of vision or any worsening for like timely reporting. But tapering of steroids is important.
And
fundus examination.
yeah, a baseline examination is very important. A baseline recording of the intraocular pressure is very important. And like you said, to explain to the parent that these drops are not to be used injudiciously. I mean, till a very long period, to use only as the doctor has advised. And you have to tell them that you're not going to use it indiscriminately whenever the child has symptoms. Okay, so without the doctor's permission, it should not be used. I think those are the advice that you have to do. And a very good examination, baseline examination of the child is very important, because that steroid induced glaucoma can really lead to blindness within years. You can see that the optic disc has gone from 0.2 to 0.9 cupping. And I mean, that's the kind of severity it can present with. So it's very important from our side to at least guide the parents very nicely, as to what steroids can also do. Okay, thank you.
Thank you so much, ma'am. So we have the mentor for the team, Dr. Ashley.
Hello.
Yeah, you're audible.
Thank you. Very good afternoon to one and all. First of all, I'd like to take a moment to appreciate the Young Ophthalmic Society of India and the organizers, the moderators, for conducting such a wonderful competition and giving an opportunity for the young residents to learn. And I also wish all the competitors the very best. A field is something which demands a high precision and long learning. So it is a chance to sharpen those skills and critical thinking. So whether you win or not, it's a gain. So it's important to not stop striving. So let's make this moment count. Thank you.
Thank you so much, Dr. Ashley. So with this, I think there was a lot of learning in various aspects of glaucoma. And with this, we'll move on to a little fun side. And I would like to invite Dr. Ritu to take
Dr. Samir, can we have Dr.
Pratima.
Pratima, please?
I think
The
she's
mentor
not.
for Team Luster.
I think she's not there.
She
Okay.
might have left. She'd been waiting in between.
She's been facing network issues. Dr. Aisha just put up on the chat.
Team
It's all
Luster,
right.
please thank your mentor for being there.
Yes.
Sorry we couldn't have her remarks, but it is so nice that your teachers are supporting you all.
Dr. Ritu?
Yeah. Thank you, Dr. Samir.
Thank you.
So all work and no play makes Jack a dull boy. So we'll all move next to round 2. That's named Pupils Got Talent, and our teams do. The rules for this round are as follows. The teams have prepared art forms such as reel, any dance, music, or digital art based on the theme glaucoma. Each team will be scored a maximum of 20 marks by the judges. And I'll go ahead with first team, that's Team Luster. Just a second.
Next station, please. नमस्ते मैडम। नमस्ते मैम। बैठिए।
क्या दिक्कत हो रही है बताओ? मैडम वो सर ना अब्बड़ पिराते एकदम आँख घरो दर्द करते मोर सर आँख सब दर्द करते और मैं 2 साल से दवाई करा तो मुझे एकदम फायदा नहीं है बिल्कुल।
कब ज्यादा दर्द होता है माँ? सुबह कि शाम को?
शाम में ज्यादा दर्द करते मैडम।
अच्छा, और कहाँ दर्द होता है? आँख में भी दर्द होता है?
हाँ आँख में कभी कभी होते हैं ऐसे इसमें पूरा सर में होके फिर आँख में करते हैं ऐसे दर्द।
ठीक है, दादी रखो।
तो मैं वहाँ दिखाया था मैडम तो बोले ड्रॉप किसी डॉक्टर का।
कितनी बार डालते हो ये ड्रॉप?
कहीं से दिन में 4 बार डाल लेती तो मैं 4 बार डालती हूँ।
अच्छा ठीक है, रखो दादी रखो। इसमें अरे अम्मा सर सीधा रखो। अम्मा जी सीधा सर रखिए।
अम्मा जी देखिए, आपकी जो आँख के पानी जाने का जो एक रास्ता है ना, वो बहुत सकरा है। उसकी वजह से आपकी आँख के ऊपर दबाव बढ़ रहा है, इसलिए आपको इतना सर दर्द हो रहा है। तो चश्मा से ठीक हो जाएगी मैडम? अरे अम्मा, हर चीज चश्मे से ठीक नहीं होती है। अगर हमने अभी आपका समय पर सही इलाज नहीं किया तो आपके पीछे की नस सूख सकती है। तो कहाँ करेंगे पड़ी मैडम? अभी अम्मा जी आपके जो रास्ता है उसे हम लेजर से एक छेद करके रास्ता बनाएंगे ताकि पानी अच्छे से जा सके। ये देखिए अम्मा जी, नॉर्मल आँख में जो होता है यहाँ से पानी जाता है, इस रास्ते से ये बाहर वाले आँख के हिस्से के बाहर में आ जाता है। लेकिन आपकी आँख में ये वाला रास्ता बंद है, जिस वजह से आँख पानी यहीं इकट्ठा हो रहा है और आँख का प्रेशर बढ़ रहा है। तो हम लेजर द्वारा यहाँ पर एक छेद बनाएंगे ताकि ये जो पानी है वो आसानी से बाहर जाए और आपके आँख का प्रेशर कम हो। Glaucoma is a sight-threatening disease in which early detection and treatment can prevent permanent blindness. So never ignore symptoms like headache, intermittent blurring of vision, redness associated with colored halos. In case of these symptoms, consult your nearby ophthalmologist, follow their advice and comply to treatment. काला पानी चुपचाप आता है पर समय पर जांच से इसे रोका जा सकता है।
Thank you, Team Luster. May I have judges' comments on these cute enactment of the OPD? I think the volume, the voice was a little different for few actors here. Julie, ma'am, we'll go with you first.
Yeah, I really enjoyed the reel actually. It was very fun and I mean such a serious matter, but the content and everything was flow and it was really made in a very fun way and very nice, very creative. Thanks.
Thank you, ma'am. Rita, ma'am, few words, please.
Yeah, very nicely done. I wish they had put in gonioscopy for an angle. The gonioscopy bit they just completely missed out, and I think that is what we are, really striking on at every ophthalmology conference. Please remember to do a gonioscopy in a comprehensive eye examination. That was probably the only thing that I thought I would be looked at.
Thank you, ma'am. This video needs a little editing now, Team Luster. Over to you. Next, Sirisha, ma'am, please.
Yeah, very nicely done. I think that the volume, the speed was doubled, I guess. So it was too fast. Maybe they wanted to condense the whole thing. So, but it was done very well, and definitely need to redo it because Van Herrick's was shown and gonioscopy was not shown. But the rest of the explanation and everything is really good. And I appreciate the fact that this topic, but maybe a little bit of editing would help. Add gonioscopy there and those disc evaluation and the rest of it you had mentioned. Thank you.
Thank you so much, ma'am.
And if possible, if you are redoing it, I know the actor is also one of the doctor, but then get an elderly lady, at least a middle-aged lady.
Thank you, ma'am. That was like bulls in the eye. Dr. Sushmita, ma'am.
No, I agree. I was just going to say gonioscopy, and Sirisha just hit it when I said you don't expect PSE in a young 20-year-old. So, yeah, just a bit of editing, but good fun otherwise. It's very sweet.
Thank you so much, ma'am.
Ma'am, we have done
Yes.
gonioscopy and gonioscopic findings are written.
Okay, they did not enact that the gonioscopy was done, but they did mention the findings of gonioscopy.
That only lens was shown.
All right. Probably we missed something. It's okay. Thank you, Team Lustre. We'll move to the next team's presentation. And that's Team Netra Ninjas. They have a digital art form here, and I'll request one of the team members to explain their art here.
Yeah,
You have 2 minutes.
Good afternoon, everybody. So, to save the eye from restriction of visual field, colored halos, and an attack of acute angle closure, you have the three Netra Ninjas, which are intraocular pressure measurement by applanation tonometry, gonioscopy to check the angle status, and optic disc evaluation. These, along with investigations like visual fields, ultrasound biomicroscopy, and anterior segment optical coherence tomography, can help us decide the plan of treatment, which can be in the form of anti-glaucoma medications or glaucoma filtration surgery with antimetabolites, and or a placement of glaucoma drainage device, which is all depicted here in this poster. Thank you so much. And in the
Thank you.
center, we have a black eye, which is the Hindi name for glaucoma, that is Kala Motia.
Thank you, Team Netra Ninjas. I'll welcome comments from our judges. Dr. Sushmita ma'am, would you like to go first?
I was thinking they would do lens-induced glaucoma somehow, so I was expecting that. But yeah, very nice arty way of putting it across. And I think it was very succinct, very interesting. Well done. I enjoyed looking at it.
Thank you, ma'am. Dr. Rita ma'am.
Yeah, I think it was very nicely, very arty kind of.
Very arty.
You know, if at all, it was all of that came in that one slide. They tried to put in whatever they could, you know, and they showed all the modes of investigation. They showed us whatever they could in that one slide, and it was very nicely done. So I think the content was, you know, very creative.
Thank you so much.
Thank you, ma'am. Dr. Julie ma'am.
Yeah, it was fun to look at and it was creative. I enjoyed. Thanks.
Thank you so much, ma'am. Dr. Sirisha ma'am, your comments, please.
Yes. So who did the drawing? Who was the artist?
Ma'am, we divided, so we did it together.
Good job.
Thank you.
Thank you so much, ma'am. We'll move ahead with the next team. That's Team Optic Oracles. They have a short video.
What's up?
I'm fine, bro. Bro, my eyes are burning crazy today.
I had the same thing last week, you know. I went to the chemist shop, got some drops, and all clear.
What drops, bro?
Some white bottle, Lexa something. You should use that. You will saying HD.
I think I will go to an eye doctor.
Bro, you and your PhDs live a little.
A few moments later.
What's up with the same? You got some style or something?
I used that top for too long. My doc says my eye pressure is higher than the petrol prices.
His pressure is 35. It's very high.
But ma'am, I'm just using over-the-counter drops.
See, steroid drops are not candy. They can damage your optic nerve. You are lucky you came in time. So no more experiments. Okay?
Okay, ma'am.
Glaucoma?
Yeah, man. I turn my eyes into pressure cooker.
Red eyes, see an eye doctor first. Glaucoma caused by self-medication is silent, irreversible, and preventable. Don't gamble with your vision.
That was amazing, Team Opticoracles. Somewhere we can just put up on YouTube. Eye turning into pressure cooker. Wonderful anecdotes. Dr. Sirisha, ma'am, few comments, please.
Wonderful, wonderful. I mean, this is so nice. I think you should now contact the GSI and whatever websites are available, put it up there. Nice. And I think the lingo will go well with the students and the youngsters. And the youngsters are the ones where we actually want to have the message across. They are busy, they don't have time, and they have easy solution.
Thank you so much, ma'am.
Thank
Dr.
you,
Rita, Dr. Rita, ma'am, yes.
completely agree with Sirisa. I think this was very nice for the young, for the youth. Everything went well with their age, and they got the message across. Basically, I know that getting the message across was nice. It could have been done a little more fancily, because at the previous presentation was so arty, so this was like, a little long, and it could have been a little more shortened and, a little more artily done, but very well done. Very, very well done.
Thank you so much, ma'am. Dr. Julie, ma'am, what are
Yeah,
your thoughts?
well done, Team Opticoracles. It had very good sense of humor in the skit, and a very good social message as well, which is, I think, very important. And I mean, it was very nicely created. I really enjoyed. Thanks.
Thank you so much, ma'am. Dr. Sushmita, ma'am.
Yeah, very nice. I mean, I echo the comments. We were all grinning away, so we enjoyed it very much. Very, very nice message. Just a little bit of tweaking, that it's not always a red eye with the steroids. So it's not as though if you have a white eye, you won't have steroid-induced glaucoma. So maybe that bit could be tweaked a little bit, but otherwise it is very nice.
Thank you, ma'am. So last but not the least, it's Team Sparklesque's turn now. They have a short video as well to share. Let's see if it can make us grin as much as Opticoracles.
As a child, I nearly saw my grandmother lose her sight to acute ankylosing glaucoma. A quick trip to the ophthalmologist saved her life and sparked my journey on becoming one myself. So here, we depict a reel presenting the same.
टीवी देखा तो ये जाना सनम, विशन का भरोसा नहीं आता सनम, आज तक था सब कुछ क्लियर, पर अब लगता है आंखों में फियर, टिप टिप बढ़ता प्रेशर, आंखों ने चिल्लाया, विशन गया धुंधला, दर्द ने रुलाया, एंग्री क्लोजर ड्रामा, क्या ये नजर का थामती इसलिए आया डॉक्टर, ग्लूकोमा का दिन, कोई करे ग्लूकोमा है, पर नानी ने फाइट जीती है, लेजर लगा के आंखों बचाया, टीवी फिर से खुल के देखा, आंखों की सुरक्षा के लिए डॉक्टर पे भरोसा.
Glaucoma is a silent thief. It damages your vision without warning and can't be reversed. But one simple eye checkup could save your sight. If you're over 40 or have a family history, don't wait. Get tested, protect your eyes before it's too late.
Wonderful. I'm stunned. This was like a Bollywood movie, having dance, music, script, Indian Idol boogie woogie. Thank you, team. Comments from our judges now. Dr. Julie, ma'am. Did you have fun?
Yeah, I had fun. I mean, the song was creative, obviously, hearing on this Bollywood song in terms of glaucoma. And the patient's plight, I mean, was acted well. Overall, good.
Thank you so much, ma'am. Dr. Sushmita, ma'am.
Yeah, good fun. Good singing, good script. Nice message across. Good fun. Thank you.
Thank you, ma'am. Dr. Sirisha, ma'am.
Very nice.
Thank you. and Dr. Rita ma'am.
Nothing
Hi.
bad. I think it was just like, it was all fun. But I had a message which went across very well. Very well scripted, very well, sung, danced, everything. Nice.
Pupils, these pupils do have talent. Thank you so much, ma'am. We end with our round 2 here. And just a second, I'm stuck with my sheet sharing. Yes. So I would like to welcome Dr. Arshi now.
Thank you so much to our esteemed judges for these two being there for the 2 rounds, for your feedback and for all the learning that the participants had because of that. And thank you to all your participants for putting up such a good show. And right now, at the wrap of these 2 sessions, these are the judges' mark session. We would invite you all to put your cameras on so we could actually have a group photo. But before that, I would like to thank all our esteemed judges with certificates of appreciation from Team YOSI and Team YOSI iROCK. So first of all, Dr. Sushmita Kaushik ma'am, thank you so much for sparing time today and your insights in childhood glaucoma. I would invite all our team participants to actually read articles written by ma'am and her team. You would understand a lot about the genomics and about childhood glaucoma. Then Dr. Rita Damankar ma'am, you're a born teacher. I absolutely loved all your feedback. Thank you so much for being here and for giving those lovely smiles to all the participants. Then we have Dr. Sirisha Senthil. Ma'am's been my teacher, and as you all know, she's also someone whose articles you must read. You will gain a lot of knowledge. Thank you so much, ma'am, for all your enthusiastic comments. And now we have the final and the youngest judge, Dr. Julie Pegu. Thank you, ma'am, for being there. And thank you for being one of the earliest people to join the webinar and for being there for the trial run as well. Ma'am's always been very enthusiastic about teaching, very approachable. Thank you to all our judges once again. And can we have one photo with the yo symbol and one just like that? Manjula ji, can you help us? And thanks to Manjula ji from Numerotech for organizing all of this behind the scenes. It's a good job and they make the backdrop for us as well. And thank you for that beautiful flyer. So, go yo.
Yeah, I will do.
Manjula ji.
Manjula ji, please take a picture for us.
We are stuck with the Ys.
I'll take one.
Yes, doctor.
All right.
Are we done?
Yes, doctor.
Okay, thank you.
Also, thank you to all the mentors once again. We would invite our judges to stay back for the further rounds. We have a quiz and a fun unscramble, but we understand that you might have other commitments and time is precious. But if possible, please do stay back. Now we can proceed ahead with the round 3. Yes, Dr. Ritu, you can start your screen share again. So all teams gear up. Quiz is something that is going to give you a lot of marks. We'll go ahead with the team round
Yeah. Is my screen visible?
instructions. Yes. So we have the knowledge nexus. These beautiful names to all our rounds have been given by Dr. Ritu. Thank you for those. So the knowledge nexus is going to have 10 questions. So all of you get attempt at it. We will project the question as a PowerPoint slide. You have to wait for us to say the question and the options. And thereafter, we'll give you around 20 seconds to respond on the chat box. So on the chat box, what we want you to do is just put the team number. So Team Luster, your team 1. Tetra Ninjas, you team 2, Optic Oracles, you 3, and Sparkle is Q4. So just put your team number once we're done reading out the question and the options. If you answer or put your number before we stop speaking out the options, you get a -2. Also, if you fail to answer After having typed your answer or given an incorrect answer, you again get a -2. So please write the number only if you're sure about the answer. A correct answer will give you a +1. And as I repeated before in the trial round as well, only one member gets to answer. So pre-decide amongst yourself who is going to be the team member who gets to answer. Also, we'll have 3 audience questions in between, and we have attractive audience prizes. So we invite all the audiences also to be ready for answering those questions. Please also submit your details if you answer them correctly, so we can send the award to you later. So let's move ahead and start the quiz. We'll have a trial question first. Dr. Sameer, please be ready with the timer. So your trial question is, where is the Charminar? Option A, Agra. Option B, Delhi. Option C, Mumbai. Option D, Hyderabad. So option 3 gets to answer first. Team D, team 3.
Ma'am, Hyderabad is the answer.
All right. So that's the correct answer. So that is the way it's going to go. So they get a mark for this. So now we'll start with the actual quiz. Are you ready? Okay, so can we have the first question, please? Which bone is not a constituent of the orbital floor? A, maxilla, B, zygoma, C, palatine bone, D, sphenoid bone. So team 2, Netra Ninjas, go.
Ma'am, B, sphenoid bone.
Can we have the answer? That's the correct answer, actually. D is the sphenoid bone. That's not part of the orbital floor. It makes up the root and the other walls. So can we have the next question, please? Teams, be ready. The most common malignant tumor of the orbit in a 6-year-old boy is A, neuroblastoma, B, rhabdomyosarcoma, C, optic nerve glioma, D, lymphosarcoma. Luster, you put the team number before we stopped, so team 3 gets to go. Team 3, optic oracles.
Ma'am, rhabdomyosarcoma.
That's the correct answer. Dr. Ritu? Yes. So rhabdomyosarcoma is the most common malignant tumor in young children. Next question, please. So we have an audience question. Teammates can take a breather. Audience question number 1. Which of the following are located in the cavernous sinus? A, ophthalmic artery, oculomotor nerve, abducens nerve. Option B, trochlear nerve, ophthalmic division of trigeminal nerve, mandibular division of trigeminal nerve. Option C, oculomotor nerve, abducens nerve, ophthalmic division of trigeminal nerve. And option D, facial nerve, oculomotor nerve, or the abducens nerve. Anyone from the audience is invited to answer. So Dr. Mehek, please speak up your answer. And also you can introduce yourself.
Good morning, everyone. Good afternoon, everyone. I am Dr. Mehek from Guru Nanak Eye Center. The answer to the above question is B. Trochlear nerve, ophthalmic division of trigeminal nerve, and mandibular division of trigeminal nerve.
So that's the incorrect answer, Dr. Mehek, but thanks for attempting. So the contents of the cavernous sinus actually have the 6th nerve and the trigeminal ophthalmic nerve and the 3rd nerve. All right. Can we have the next question, please? Teams, be ready. Which of the following is the classical triad of Radon-Ego syndrome? A, otorrhea, headache, and diplopia. B, headache, fever, and ear pain. C, diplopia, proptosis, and ear discharge. D, ear pain, neck stiffness, and vomiting. So, team 4.
And option C, diplopia, proptosis, and ear discharge.
So you get a -2 because the answer is ear discharge, headache, and diplopia. Radon-Ego is petrositis or the apical petrous bone syndrome that's usually inflammatory and has ear discharge with diplopia and headache in the patient. But good attempt. Be careful about when you answer. Let's go to question number 4 now. All of the following are characteristics of congenital third nerve palsy except A. Esodiviation, B. Abnormal pupillary function, C. Hypotropia, D. Ptosis. So team 2 gets to go first. Team 2, Netra Ninjas, please answer.
Ma'am, B, abnormal pupillary function. No, hypotropia. It is hypotropia.
So that's the incorrect answer. The answer is esodiviation. So you need to know your nerve functions before you get to understand this. Let's go to the next question. Dr. Ritu, Dr. Sameer, please keep a mark of this. Which disease is associated with this pathology in children? Take a note of the image that's posted here. A. Wilson's disease. B. JIA, juvenile idiopathic arthritis. C. Congenital glaucoma. D. Retinitis pigmentosa. So team 3 gets to go first. Optic oracles, please unmute.
JIA, ma'am.
Good. So that's the correct answer. That's a band-shaped keratopathy that you could see over here, which is commonly seen in JIA patients. Okay, we can move on to the next question. So audience question. Again, audiences be ready. Which of the following is regarded false for Fuchs endothelial dystrophy? Okay. The first is one end of the spectrum has corneal gutata. At the other end are epithelial bullae. Option B, symptoms usually consist of blurry vision and pain, which is worse in the evening. C, typically stromal edema develops before epithelial abnormalities are noted. D, penetrating keratoplasty may need to be undertaken at the time of cataract surgery, even though corneal symptoms may be minimal or non-existent. Anyone in the audience, please?
Good afternoon, ma'am.
Yes, Dr. Shireen, you can answer.
Ma'am, the answer is B. Symptoms are consistent of blurry vision and pain worse in the evening.
That's absolutely right. Dr. Shireen, can you tell us why that's false?
Ma'am, the symptoms will be worse in the morning time.
Absolutely
Yes.
right. So Dr. Shireen gets an audience award. Congratulations. Again, please, Dr. Sameer, have a note of that. Can we move on to the next question? That's going to be for the teams. Question number 6. Which study established the efficacy of anti-VEGF monotherapy for PCV? A. Everest 2, B. Planet, C. CATT, or D. Anchor? Any team wants to take a shot at this? I see no takers. Okay, team 2, Netra Ninjas. Unmute, answer.
Ma'am, ma'am, B, planet.
Good. So they've got the right answer. It's Planet. The rest of the trials were actually for Netra Ninjas, if you can give an answer. All right, I'm going to let you guys study about this. What is Anchor? What is Marina? What's Everest? Okay, next question, please. Question number 7. Side effects of prostaglandin analog drops include all of the following except A. Increased iris pigmentation, B. Conjunctival melanosis, C. Hypertrichosis, D. Cystoid macular edema. So I would want my other moderators to actually tell me who were the ones to answer after the options were put up.
I think it was team 2.
Team?
Team 2.
Team 2. So team 2, Netra Ninjas, go. You don't get extra marks if you guys put your team number before the options are said out.
Ma'am, B, conjunctival melanosis.
All right. Can we have the answer here? That's right, actually. So conjunctival melanosis, team 2, good. So you get a +1. Can we move on to the next question? Nuclear brunescence increases with higher concentrations of which lens protein? A. Alpha crystalline, B. Beta crystalline, C. Gamma crystalline, or D. Main intrinsic polypeptide? Any team? Okay, so 20 seconds up. We're going to give you the answer. No attempts for this question. So the answer is D. Main intrinsic polypeptide. So you need to know what proteins actually change, which concentration increases and which decreases, which causes the opacification in the colors. Okay, moving on to the next question, please. Audience question 3. Again, audiences, you have another attempt. The question is, which test may be useful in a patient with bilaterally narrow angle anterior chamber angles and normal intraocular pressure? A. Water drinking test. B. Prone darkroom test. C. Supine lightroom test. And D. Dexamethasone provocative test. Okay, Dr. Mehek, please attempt your answer.
Ma'am, answer is B, prone darkroom test.
Good, Dr. Mehek, that's the right answer. The prone darkroom test is the provocative test that we use for angle closure glaucoma. Okay, can we move to the next question? Teams, be ready. Which is the most likely diagnosis? Optic nerve glioma, benign mixed cell tumor of the lacrimal gland, C. Cavernous hemangioma, D. Metastatic breast cancer. Take a careful look at the image. I hope you all can spot the pathology. Team 3.
Optic nerve glioma, ma'am.
So that's the wrong answer. Can you see where the swelling is actually? It's not along the optic nerve. So that actually causes a fusiform enlargement within the optic nerve. This, as you can see, is adjacent. So this is a cavernous hemangioma, which is one of the most common benign lesions that you can find. Good attempt though. Next question, please. And that's going to be the last question for our teams. Be ready to make up. Which of the following conditions is pembrolizumab approved for? A. Multiple myeloma. B. Active thyroid eye disease. C. Metastatic melanoma. D. OSSN or ocular squamous neoplasm. So team 4 is the first person to have put it up. Am I right, Dr. Samir?
No, team 4 had, before the options were read out, they had.
All right. So team 2.
Metastatic melanoma, ma'am. C.
That's right. That's the correct answer. Team 2. So team 2, you guys get a +1. Good attempt by all the teams. You should have taken a little more care about when you had to type. All the other moderators, please take note about the minus negative marks that they've incurred because of the.
I'll just mention the marks for this round alone so that there's no confusion
Yes.
afterwards. So team 1, the score remains unchanged. Team 2 has got +2 and team 3 remains unchanged. Team 4 got -2 for this round.
All right, you have another round to go and you can just make up for those now. I'll give over to Dr. Ritus to have a very interesting and fun unscrambled round. Have fun.
Thank you, Dr. Arshi. So you must have all been bored with the regular type of questioning. Let's go to kindergarten times. Unscrambled round that's named Wordsmith War. I'll brief you all through the instructions now. Your team will be playing one by one, followed as in the order mentioned before, Team Lustre, then Netra Ninjas, Optic Oracles, and Sparklesk. There'll be 6 jumbled words that would be flashing on your screen. You'll have just a minute to solve it, and you'll have 1 mark for every correct answer that you give. This is a trial questionnaire where you can see it's not an ophthalmology related question, but you get to see scrambled name. Get a minute, and then following that, am I audible? My screen shows that somehow my internet connection is unstable. Dr. Arshi? Am I being followed?
Yes, you're okay.
Yes.
Ritu. Can you just,
Okay.
you were fine.
Yeah, okay. So we'll begin with the first team now. Team Lustre, buckle up. Your time starts now. Start unscrambling as many as you can.
Ma'am, first is television. Fifth is tear. Third is anisocoria. Sixth is tropicamide.
You have 30 more seconds. You're doing great.
Fourth is refraction. Oculomotor. Second is oculomotor.
Right. You have attempted all of them. Go
Yes,
to
we've
the
attempted.
answers. The team gets a +6 in this round. Moving to the next team, Team Netra Ninjas. Your time starts now.
The questionnaire is not displayed and the time is.
I can view it on my screen.
Second one.
Second is blepharoplasty. Sorry, not blepharoplasty. First, tonometry.
Try Netra Ninjas. You have few seconds. Just say something.
Chalasia.
You didn't have any negative marking. Well, you tried attempting. The first one was tonometry. I think they answered it right. You get a +1 in this team. The next team, let's see how much you can score. Team Optic Oracles, your time starts now. Optic Oracles, you have half of the stipulated time left.
Ma'am, cotton wool spots, Kogan twitch, Marcus gun, Horner syndrome, Correctopia. Correctopia. एक और बचा है congenital हो गया सारा कौन सा
5 more seconds. Good, good, good.
single rose sign
Well, time's up. You managed to get 5 of them. That was Wash's ring you were troubling at.
oh.
Good going. Team 4, Sparklesk, let's shimmer. Your time starts now.
Ma'am, fourth one is iritis. Time. Sixth one is time, ma'am. First one is lag of thalamus, ma'am. Ophthalmos lamellar lamellar hole is second one, ma'am.
Hello.
That was ophthalmos. There was no G in it. You could manage 3 out of them. Iritis, tie, and laminole. Well done. I had fun. I'm pretty sure you guys had fun too. Team 1 got +6, team 2 got +1, team 3 +5, and team 4 fetched +3 in this round.
Yes.
Good. Nice. Well, Dr. Samir, you can wind up this session. Over to you.
So thank you everyone. First of all, we are very grateful to the entire council of YOSI, the governing council, for supporting us, and obviously Dr. Nupur ma'am, who started this with this initiative. And we have had 8 prelim sessions till now, which have been very, very successful. And obviously my co-moderators, Dr. Arshi ma'am, Dr. Ritu, and Numerotech for, supporting us conducting this webinar, and to all the judges and the participants who, all of us know that, Sunday is probably the only free day that you get in your residency, and that too is not, definitive. You tend to have duties on Sundays as well. And, at the end of the day, it doesn't matter whether you win or lose. It's all about exposure, coming out and, projecting yourself, refining your presentation skills, and, interacting with other people. So with this, big thank you. And I hope all of you had a good time, had lots to learn. And with this, we'll present the certificates. So thank you, Dr. Akshita, for taking part in this. Dr. Amita, then Dr. Amisha, Dr.
Can
Arushi,
we have your videos on so we can see you? You've all done such a great job.
Dr. Aisha, Dr. Gagandeep Kaur, Dr. Habiba, Dr. Lakrawala Hussain, Dr. Navya Shri, Dr. Priyanshi, Dr. Simran, Dr. Swarnima. And with this, we'll continue our tradition of clicking the photo, ending the webinar with the YOSI symbol. So thank you everyone for joining us. And we have Nupur ma'am also with us. Nupur ma'am, you would like to say anything?
Hi everyone. I couldn't be there for the. We can ask Manjula to stop the live stream first. Yeah.
1 second,